Hi, and welcome again to the troubled meetings that are Zoom related. We've got some more people coming in. So my name is Neil Loach. I'm the president of IOH, and I shall be looking into this and doing a bit of a post-mortem because it isn't good enough. So again, it's happened. So basically, we're now recording the meeting, and I'm going to hand over to Laura James, who is the Head of Clinical and Peer Support for Prostate Cancer UK. So over to you. Thank you very much for joining us, Laura.
Pleasure. Hi everyone, thank you Neil, and thanks everyone for inviting me and having me this evening. As Neil said, I'm Laura James, Head of Clinical and Peer Support Services at Prostate Cancer UK. I'm going to take you through a presentation this evening in relation to sort of prostate cancer and what we do at the charity. Hopefully you're familiar with Prostate Cancer UK. You might know us from that little picture at the bottom of the slide, which you can see is our Man of Men badge, which is a man with lots of other little men inside of it, and it's something that quite a lot of football managers and people in sport wear. We are the leading men's health charity, and we have particularly grown in the past couple of years in terms of raising awareness of prostate cancer, with celebrities such as Bill Turnbull and Stephen Fry speaking out about their diagnosis. But as I said, I'm Laura. I'm Head of Clinical and Peer Support Services, which means I head up two teams within the charity. I head up our clinical services team, which is our specialist nurse team. We are the only charity in the UK that's staffed exclusively by specialist nurses. Generally, it tends to be a mix of volunteers, nurses, but we only have specialist nurses working within our team who have a background in either oncology, urology or palliative care. And I also head up our peer support team, and that's the team that look after support groups, our one-to-one peer support service and our online community. But I'll go on to tell you a little bit more about what we do in our services as we get into the talk. I'm conscious of time, so I may have to move quite quickly through the presentation to do my best to sort of get everything in. But there is a chat box, and please do put questions in the chat box, and Neil will sort of let me know if there's anything in there to sort of ask me as we go along, and I'll do my best to try and leave us, if we can, sort of 10 minutes at the end for any questions. So also do please feel free to hang on and ask me questions at the end. I really don't mind either way. Can I have the next slide, please, Neil? So these are the aims of the session. As I said, there's a few things to cover there: to understand the nature of prostate cancer and who's affected by it, to understand the issues around detecting and diagnosing prostate cancer, to understand the issues that men face regarding the PSA test, and to understand how the specialist nurses at Prostate Cancer can hopefully support you in your areas of work. Next slide, please. So let's kick off with the prostate. What is it, where is it, and what does it do? So it's a small squishy gland. It's about the size of a walnut, and as you can see it on that diagram, it sits underneath the bladder and around the urethra, which is obviously the tube that you pass urine through. Only men have one, and its main function is in the production of semen. Neil, if you could just push enter again, you should get up a little bit more detail that comes up under those two. That's it, and then if you just push it once more, sorry again. That's it. So that's lovely. Thank you. There are three main conditions that can affect the prostate. There's an enlarged prostate, there's prostatitis, and there's prostate cancer. And obviously two of those are benign conditions, which is an enlarged prostate and prostatitis, and then there's obviously prostate cancer. Now, it is possible to have more than one condition at the same time. So for example, you could have an enlarged prostate and you could also have prostate cancer, but having an enlarged prostate does not increase your risk of prostate cancer. Next slide, please. Just a few kind of facts and figures on prostate cancer. So over 47,500 men are diagnosed with prostate cancer every year. Over 11,000 men die of prostate cancer each year. But to sort of put the other side to that, more than 400,000 men are living with and after a diagnosis of prostate cancer. So hopefully that kind of reiterates that point that, you know, prostate cancer is a cancer that, you know, men can live with for a considerable period of time. even if it's diagnosed with a more advanced stage, which is obviously quite different to quite a lot of other cancers, where if you're diagnosed with an advanced stage with it, that can sometimes be quite life-limiting. Prostate cancer is not like that, and there will be men who can be diagnosed with an advanced prostate cancer, who will live with that for many, many years. And as I sort of touched on previously, it is the most common cancer in men, and it's now the most commonly diagnosed cancer in the United Kingdom. And as I said, we really have seen a real increase in the awareness of prostate cancer, certainly in the last 18 months to 2 years. And, that's only going to continue to grow, particularly with COVID and with the pandemic, because one of the things that we've really seen impacted is referrals. And I'm sure you're all aware that, people have been worried about going to their GP or going to the hospital for 2 reasons. They've been fearful about catching COVID potentially in those environments, and they've been fearful about overwhelming the NHS and health services. And unfortunately, what we've seen as a result of that is that, across all cancers, there's been a significant drop in referrals, and only now are we, starting to see those kind of referrals climb back up again. So, what we can expect to see over the next sort of 18 months, 2 years and beyond is almost all of that kind of catch up happening, and all those people starting to go through the system who need to be referred and then need to be treated. So we only really expect to see those figures rising. Next slide, please. So just to go on to talk a little bit about risk factors, and you may sort of wonder why I'm talking about risk factors first and symptoms second. And that's because for most men with early stage prostate cancer, they don't have any symptoms. So that's why it's so important that men know about their risk. And actually something that we've developed at the charity is a risk checker, a 30-second risk checker tool, where men can go onto the website and they just put in risk checker, and it actually comes up on our homepage. They don't even really need to search for it. They put that in, and it takes them to a tool that asks them a series of questions, and based on their responses to those questions, at the end it will give them a guide on what they should do. So for example, if the answers to their questions indicate that they're a man at a higher risk of prostate cancer, it will give them guidance on what to do. If it were to come out that they were, a man at low risk, or sort of, the partner of somebody sort of affected by prostate cancer, it would encourage them to go on and share that risk checker tool. So Neil, sorry, if you wouldn't mind just pressing return again 3 times. Apologies, these slides work on a bit of a delay. That's lovely. Thank you, just to add that detail. So as you can see there are 3 main risk factors for prostate cancer. The first one is age. It mainly affects men over the age of 50, and risk increases with age. The average age to be diagnosed is between 65 and 69. Ethnicity is another risk factor for prostate cancer. So black men have an increased risk of prostate cancer. It's 1 in 4 black men who will be diagnosed with prostate cancer in their lifetime, and that's double the overall 1 in 8 risk faced by all men. We don't really know why that is. We think it's to do with genetics, and there's a huge amount of work and research going on into that. And there's a big trial at the moment going on called the Profile trial, which is trying to look at exactly that, why are black men at an increased risk of prostate cancer. And the third risk factor there is family history. So you're 2.5 times more likely to be diagnosed with prostate cancer if your father or brother has been diagnosed with it, and that's compared to a man with no affected relative. So that's why it's so important, as you can see, that men know their risk factors, because prostate cancer is quite a different cancer in the sense of, as I said, certainly with early prostate cancer, men often don't have symptoms. So you really can't rely on that as you can with some other cancers as a kind of way of driving people to see their GP or raising a concern. There wouldn't necessarily be, with some cancers, obviously, you'd be looking for a change in bowel habit or a lump or something like that, and that won't always be the case in relation to prostate cancer symptoms. It's probably also mentioned here, one that's not on this slide but worth mentioning, body weight. Obviously nobody knows how to prevent prostate cancer, but obviously staying a healthy weight, as is the case for many cancers, may be important. And research does show us that being overweight or being obese increases your risk of getting a cancer that's more likely to be spread. So those are the 3 main risk factors for prostate cancer. Next slide, please. But that, I've touched on symptoms, and I've said, that they're are generally no symptoms for prostate cancer. But that's not always the case, and some of the things to be aware of are, sorry Neil, if you could just press enter again. Yeah. And yeah, these are some of the symptoms that can be indicative of prostate cancer. So things in relation to urinary symptoms, so frequency, urgency, hesitancy, flow, dribbling, all of those urinary or sort of waterworks problems can be an indication of prostate cancer. I would probably caveat that by saying the likelihood is that they are to do with something else. So urinary symptoms are the main cause, an enlarged prostate is the main reason for urinary symptoms in men over the age of 50, and they will absolutely see those things there like urgency, hesitancy, frequency, poor flow, dribbling. We often sort of relate it to thinking about hose piping. You know, if you're in the garden, you step on a hose pipe and you start to see that sort of stop flow and that stop start and that dribbling and that sort of interruption to the flow. Those can all be symptoms that relate to an enlarged prostate, because if you think about it, what's happening is the prostate is growing, it's getting bigger, and it's pressing on that water pipe. So in this case, the hose analogy, and obviously it's squeezing on that pipe and sort of stopping the flow. You'll see there erectile dysfunction, and for some reason, I'm not sure why it hasn't come up, but another one that comes up is blood and urine. Whilst they can be symptoms of prostate cancer, they are not common. So if a man were to be having problems around erectile dysfunction or noticing blood in his urine, it would be unlikely that they would be something to do with prostate cancer. But, you know, if you are speaking with men and they have noticed a change to their urinary habits and they have noticed these types of symptoms, and it really is very much about noticing what's not normal for the individual. You know, and if they are finding that, you know, perhaps whereas they maybe got up once or twice a night, actually in the last sort of 3 months, 6 months, they've noticed that they're getting up 3 or 4 times a night to go to the toilet. That would be something that we would absolutely want them to flag up and talk to their GP about, because as I said, the likelihood is it may be something to do with an enlarged prostate, but it could be a symptom of prostate cancer. Next slide, please. So, do these symptoms mean a man has prostate cancer? Hopefully I've sort of answered that for you, but if you could just press return again for me. No, they don't. But what it, you know, if a man is experiencing these symptoms, what it does do is it gives a man an opportunity to visit the GP. And obviously, if they are able to rule prostate cancer out, then those kind of bothersome symptoms can be treated. And as I mentioned, the most common cause of urinary symptoms in men over the age of 50 is having an enlarged prostate. And actually, an enlarged prostate can be treated really easily. Often in the first instance, it's about looking at lifestyle. So, for example, you know, is that man perhaps drinking too much tea or coffee or something like that? Certainly maybe in a couple of hours before he's going to bed. So it might be about sort of looking at drinking habits or retraining the bladder or something like that. If that doesn't do the trick, then obviously it's moving on to medication, and there's a lot of medication that's really good at controlling the sort of symptoms that can come with having an enlarged prostate. And if that doesn't work, then there is the kind of next step, which is the surgery option. And again, the surgery options for having an enlarged prostate are very good and generally tend to last sort of around about the 10 to 15 year mark before a man might need to have something done again. So, you know, if you are talking to a man or you know somebody who is suffering with an enlarged prostate and they kind of think, oh, this is just something I've got to put up with, it really isn't. You know, there are good treatments out there and there are good things that can help. Next slide, please. Just to clarify there. So what happens if a man has noticed those urinary symptoms, you know, and is concerned about that, you know, what's the next step and what the GP might do? So obviously, if a man is talking to you and he kind of says to you, look, I have noticed a change to my urinary habits, or I'm getting up more at night, or you know, I'm concerned because there's a family history of prostate cancer, or my brother's just been diagnosed with prostate cancer, any types of conversations like that, and he wants to sort of take the next step in terms of having a conversation with his GP about it. There are 3 different things that a GP can do. So the first one is a urine test, and obviously that's to rule out any type of urine infection. So, you know, for example, if a man were to go to the GP and say, I've noticed some blood in my urine, or I'm going to the loo much more often, I'm having to rush to go to the loo, you know, when I need to go, I really need to go type thing, that the GP will just dip and check the urine and obviously rule out any type of infection, which is a very simple thing to be able to do, because obviously those symptoms can be caused by an infection as well. The other thing is the PSA test, and this is something that you may or may not be familiar with and you may or may not have heard about. The PSA test is a blood test, and it stands for prostate-specific antigen, and it measures the total amount of prostate-specific antigen that's in the blood. Now, if a man has a raised PSA, that may indicate a prostate problem, but not necessarily prostate cancer. So something like having an enlarged prostate, having prostatitis, which is one of those two benign conditions that I mentioned at the start, and is an inflammation or an irritation of the prostate, both of those things can cause the PSA to be raised. So having a raised level, as I said, may indicate a problem, but not necessarily cancer. It could be caused by enlargement, it could be caused by inflammation or infection or irritation. There are also other factors outside of the kind of what's going on inside that can affect the PSA test as well. So, for example, if a man were to sort of vigorously exercise, you know, in the 48 hours before he were to have a PSA test, you know, for example, he were to run a marathon or he were to be riding a horse or something like that, those types of things can influence the PSA test and possibly can give a more elevated reading than you would expect. But what happens, you know, PSA, as I said, is a protein and it's produced by cells in the prostate, and your PSA level will naturally rise as you get older. So that's why, you know, as a man gets older, there are sort of higher thresholds and higher levels in relation to where we would expect the PSA to be. But, you know, a PSA test is not a test or a tool that can be used on its own to sort of indicate prostate cancer or to rule it out, and I will go on to talk about that in a little bit more detail in a minute. But what's really important is that your GP looks at your PSA level in relation to other test results as well. It's not an indicator, you know, it's not a diagnostic tool, it's an indicator test. So it can indicate that there may be a problem, but it can't diagnose prostate cancer on its own. Just a little bit more in relation to the PSA test, and probably something that if you're not aware of, it's important to know that you can share with men. You have a right to a PSA test if you're over the age of 50, and you have the opportunity to talk through the pros and cons of the PSA test with your GP, and I'll go on to talk about that a little bit more in a minute. But, you know, we do hear about men who will come to us at Prostate Cancer UK and say, I was refused the PSA test because I didn't have any symptoms, for example. And that, you know, it is every man's right over the age of 50 to ask for a PSA test. So, you know, it's absolutely important that if that happens, they keep knocking on that door and they keep asking for it. But what is important is that they understand the benefits and the limitations to a PSA test. And as I said, that all men over the age of 50 are entitled to ask for a PSA test. But if you are a man under 50, so for example, you know, if you're a man of 46 or 47 and you're black, or if you have a strong family history of prostate cancer, so for example, your father and your brother have both been diagnosed with prostate cancer, you may well want to start having these conversations with your GP from the age of 45. And you know, unfortunately, it's not the case as when you're a man over 50 that you can insist that you have that PSA test done. But, you know, if you were a black man, age 47, with a brother diagnosed with prostate cancer, sitting in front of your GP saying, look, you know, I'm aware that I've got these two increased risk factors for prostate cancer, and, you know, I really want to have a PSA test done. I understand about it. It would be a strange situation with a GP where they wouldn't be, you know, they wouldn't be in agreement to doing that. But just really important for men to know that it is their right to have a PSA test done. Next slide, please. And just press return again. That's it, lovely. So yeah, the third test that the GP can do is the digital rectal exam. And obviously, as you can see, there's the diagram there. The doctor puts a finger up the back passage and feels for the size and the shape of the prostate. and you know, a prostate that's sort of hard or bumpy or sort of feels irregular may be an indication of prostate cancer. You know, it's a test that often men can feel quite funny about, you know, and can sometimes feel a bit embarrassed about or uncomfortable about, but you know, it really isn't painful, and you know, men do say to us that it's a discomfort rather than a pain, and the majority would say that they would rather have that, you know, few sort of seconds to a minute of discomfort. But it's a useful test, and it's a helpful test, you know, alongside the other ones that we've mentioned, because obviously, you know, if that prostate is feeling sort of hard or lumpy or bumpy, then that may be an indication of something that needs looking into further. So those are the sort of main things that the GP can do in terms of that first initial appointment. Next slide, please. So why not screen all men for prostate cancer? You know, it's a great question. We have screening programs, obviously, for other cancers. So why not screen all men for prostate cancer? Next slide, please. This is from the NHS website, and the reason for that is because there's currently no screening program for prostate cancer in the UK. This is because it has not been proven that the benefits would outweigh the risks. Although screening has been shown to reduce a man's chance of dying from prostate cancer, it would mean many men receive treatment unnecessarily. And this comes from the NHS's website. And just to put a little bit more detail to that, if you could go on to the next slide for me, Neil. Thank you. So this has come about due to a trial. It was a big study that was done about probably getting on for about 10 years now, and it was the European randomised study of screening for prostate cancer. And it was the largest randomised trial of PSA testing for prostate cancer, and as you can see, it involved a huge number of men, you know, in a big sort of age bracket, across sort of lots of different parts of Europe, particularly Sweden, I think it was done in. And what they found, that there was a significant reduction in the risk of death from prostate cancer by 21% after 13 years of follow-up. And so basically, to sort of simplify that, to save one life, 1,410 men would need to be screened and 48 treated. And to sort of make an equivalent for you for that with breast cancer, which is obviously the main sort of cancer that affects women, and put that into perspective a little bit. In terms of breast cancer screening, to save one life, 4 women need to be treated. Whereas if you can see here, to save one life, 48 men would need to be treated. So that's why, you know, it's not there yet in terms of screening. Next slide, please. Lovely, thank you. So what we do, because we don't have a screening program, what we have in this country, in the UK, is an informed choice program. And we use something called the Prostate Cancer Risk Management Program, which is the PCRMP. And what this is it's a set of guidance, you know, and it provides GPs and it provides practice nurses and nurse practitioners working in primary care with the information to counsel men who don't have symptoms, aged over 50, who ask about PSA testing for prostate cancer. So if you are ever having a conversation with somebody, and as I said, you know, they sort of come back to you and say, look, I'm having a real problem getting any cut through with my GP or anything like that. You know, one of the things you can always do is direct them to the Prostate Cancer Risk Management Program. And as you can see, that's something that's available on our website. It's available on the NHS website as well. And it's got some really good advice for men who don't have any symptoms, you know, any urinary problems, but they're aged over 50 and they want to know more about the PSA test. Next slide, please. So just to sort of talk a little bit more about the PSA test. As I said, it's a blood test that measures the amount of protein in prostate cells, and obviously PSA is present in cancerous cells, but it's also present in non-cancerous cells as well. All prostate cells produce PSA. What you're really looking at for a man sort of aged between 50 and 69 is a PSA of under 3. If you could just hit the turn again for me there. Just a couple of other bits that come up. Lovely. That's great. But whilst I'm saying that, in terms of, you know, you're looking for a PSA of under 3, a level that's raised above 3 doesn't mean that a man has got prostate cancer, and it also is the case that a level below 3 doesn't mean that a man doesn't have prostate cancer. So you can just see again that whole thing about screening and how, you know, a PSA test is not accurate enough to be used as a screening tool. And just to put a little bit more detail onto that, 75% of men with a raised PSA will not have prostate cancer, whereas 15% of men with a normal PSA will have prostate cancer. So, you know, it sounds a bit like we're saying, oh, the PSA test, you know, the PSA test was never designed to be used as a screening tool or anything like that. You know, actually, once a man's been diagnosed with prostate cancer and treated, the PSA test is the best way we have of knowing how that man's treatment is going, because usually if the PSA were to start to rise, or, you know, we were to be able to detect a PSA where it had been an undetectable PSA due to treatment, that would be is usually the first and the best indication of something changing and going on. But, you know, the PSA test has evolved over time, and obviously now it, you know, it is used as you know, along with the digital rectal exam, but probably more so as the first kind of test that a man will have done when they do approach their GP. And, you know, the really important thing is that it has benefits and it has limitations, it has advantages and it has disadvantages. And that's why it's so important that a man has a conversation with the GP about the PSA test, so that he understands those benefits and those limitations and what it may or may not be able to tell him. So, you know, obviously the pros to it, the advantages to it are that obviously it may find a cancer before you have symptoms. And as we said, you know, with prostate cancer, certainly with early prostate cancer, men often don't have symptoms, so you can't rely on that. You know, so if the PSA test picks up a raised PSA and that man then goes on to be further tested and investigated and is found to have a prostate cancer, the likelihood is you found that at a much earlier stage. It can also find a faster growing cancer, again for the same reasons at an earlier stage, where, you know, tests and treatment and intervention will normally be, you know, be advantageous, rather than finding it at a later stage further down the line when you may not be able to cure the prostate cancer. It's about keeping it under control. Prostate cancer is a very curable cancer, and, you know, if it's caught early, you know, it has very successful outcomes in terms of curing it. And it's only when a prostate cancer gets to that more advanced stage that it can't be cured, and then it's about keeping it under control. Another advantage to it, obviously, is that, you know, if you are a man who's at a higher risk of prostate cancer, so, you know, if you are a man with a significant family history, regular PSA testing could be helpful. You know, if you are at that increased risk and you are doing regular PSA testing, you stand more of a chance of picking something up at an earlier stage. But, you know, obviously there are also the cons on the other side of things as well, or the limitations to it. As I've said, it can miss cancer, it's not foolproof, you know, and it may not detect a cancer that's there. If you do find, you know, if the PSA is raised, that man then potentially starts down a pathway of more tests and investigations that, you know, can be quite invasive in some ways. Although, you know, what I'm talking about there is a biopsy, but I think it's important to kind of caveat that by saying that, you know, a few years ago, biopsy was often the first thing that was done, and actually that's changed a lot now, and you know, in pretty much most cases it will be an MRI that's done first of all, and they would only then go on to biopsy that man if the MRI were to show something of concern. So we've certainly moved forward in that area of where they would rush to biopsy men, which is obviously, you know, quite an unpleasant and invasive procedure. And I think, you know, another thing to say about the PSA test that can be potentially a limitation to it is that obviously prostate cancer is generally a slow-growing cancer. And, you know, if, for example, you were to do a PSA test, let's say on a man in his 80s, and you were to find there a very slow-growing cancer that was going to have no impact on that man's natural lifespan at all, obviously, if you find something like that there, that man then has to live with that sort of worry and anxiety of prostate cancer for the rest of his natural life, and know about something that would have had no impact on him at all. So it's just important to think about it from that point of view as well. Next slide, please. Thank you. So these are a couple of case studies, and normally we sort of, would sometimes take a little bit of time to sort of perhaps go through that and talk about that. But as I said, I am conscious a little bit about time, and I wanted to put these in because I just thought they were a good couple of examples for you of the types of people that contact the specialist nurses at Prostate Cancer UK. So this is a very typical call that we might get from somebody. It's a man called Mark. He's 60 years old. He's white British. He's got no family history of prostate cancer. But what he's found is that he's been getting up the past 2 or 3 months to pass urine 3 times at night, and that's not necessarily because he's had a lot to drink, or maybe he's had some alcohol or something like that, and he's noticed some hesitancy at all. So what would we do? What would we say if we took a call from somebody like Mark? If you could just hit the turn for me, Neil. Lovely, thank you. And just once more. Great. So if we took a call from somebody like Mark, who was telling us about this is his history and this is what he's noticed that's a change for him and this is his concern, we would be talking to Mark about seeing his GP. So to discuss his risk factors, because he is 60, so he does have an increased risk of prostate cancer because he's getting older. He's heading more into that age bracket where prostate cancer is more of an issue. Obviously, he's having some symptoms in the sense of he's noticed that he's got some hesitancy when he's passing urine, and he's getting up to pass urine more. He's getting up at night to go to the loo. So we want him to make his GP aware of his risk, aware that he's noticed a change to his urinary habits, and to have a conversation with his GP about if the right thing for him to do is to have a PSA test. So that's a very typical type of call that we might take. Next slide, please. And this is just another example. Again, this is a really common thing that a man might sort of get in touch with us and be talking about. So this is David. He's 45 years old. He's Black Caribbean. His father has had prostate cancer, but he's got no symptoms. So nothing's changed. No sort of changes to his waterworks or anything like that. But he is aware that he is at an increased risk of prostate cancer. So if you could just press return for me again, Neil, thanks, just twice. That's great. Absolutely. So somebody like David, if he contacted us and he was telling us that this was his background and this was his story, we'd absolutely be having a conversation with David about seeing his GP because, he is at an increased risk. His father's had prostate cancer and he's a Black man. So those are 2 of the risk factors for prostate cancer. And as we've said, we know that, certainly with early prostate cancer, men don't have symptoms, so we can't rely on that. So we would really be wanting David to have a conversation with his GP now at the age of 45 because he does have those 2 increased risk factors. So rather than waiting till he's 50, having that conversation at a younger age to talk about those risk factors and again to have that conversation about if a PSA test is the right thing for him. So that's just a couple of examples of the types of people who might get in touch with us. Next slide, please. Just a little bit about Prostate Cancer UK. So as I said, we are the largest men's health charity in the UK. And what the specialist nurse team do, which is obviously the team that I head up alongside peer support, is we give information and we give support. And we do that through a number of different platforms and services. So the main way of people contacting us is through the telephone there. So as you can see, it's a free phone number, 0800 074 8383. And we work Monday to Friday. The service is available from 9 in the morning till 6 in the evening, and we do a longer day on a Wednesday from 10 till 8. We don't work weekends, but what we do have is a callback service. So if anybody does contact us out of hours, we will get back to them within 24 hours, obviously, unless it's on a Friday, and then we pick it up on a Monday. So the telephone is the main way of people contacting us. I would, roughly about 70% of our contacts through a year come through the telephone. We also have 3 other ways of contacting us as well that are our direct services. One of those is live chat. So if you go onto our website, if you're looking at a health information page, for example, a little chat box will pop up that says, we can see you are looking at diet and exercise, for example. Would you like to talk to one of our specialist nurses about that? And people can then have a chat with us. Email, people also can email us as well, and social media. So we get a lot of sort of inquiries through Twitter and Facebook. And it's really interesting actually, because you tend to find that people use different platforms to contact us for different things. So emotional support is a huge thing that people contact us about, and people very much do that through the telephone. Whereas if they want to ask quite factual, quick questions, so you know, I'm going to have a catheter in after surgery. How long is that catheter going to stay in for? That's often something they'll use live chat for. You know, they just want a quick kind of answer and response. If they want to know about a clinical trial, so for example, you know, they've heard about a trial and they want to know more detail on that and how they can possibly join up to that trial, that's often the type of thing that they will email us about, because, you know, we give an incredibly detailed response to that. If it's something like they want to know about the PSA test, or, you know, why don't you have a screening program, for example, that's often something that will come through social media. So, you know, Twitter, Facebook. So it's really interesting that people use the services in different ways to contact us about different things. But, you know, you can see I've put there historically men in general don't pursue cancer information, and that's definitely changing, and that's definitely got better, and I think, you know, men are much better at talking about, you know, and looking for information. But, you know, I would have to say that we do still hear very strongly from men that it is often their partners, their wives, their partners, their girlfriends, their family members, children or grandchildren, who are often the driver and the push for them to do something about it. And, you know, it's really, really common to hear a man kind of say, oh, I wouldn't be here, you know, I wouldn't be having this conversation with you, ringing you, or, you know, if it wasn't for my wife sort of, you know, giving me this leaflet or telling me to get in touch with you or something like that. It's a really common thing to hear. Next slide, please. So just a little bit about our services and what we do. So as I've mentioned, that the main direct services that we have are email, social media, live chat, and telephone, but we also have some bespoke services as well. So we have, you can see there, our sexual support service. So this is a service that we offer because side effects, sexual side effects are very common after surgery or radiotherapy treatment for prostate cancer, particularly surgery. So we offer a sexual support service where men can refer themselves onto that, and some of our nurses who are particularly trained in that area will talk to them about treatment, about the kind of psychosexual side of things, you know, about how they can sort of still have intimacy in their relationships and that kind of thing. And that's a service that has grown massively over the past year, because, you know, that kind of thing has really fallen by the wayside with the pandemic. You know, those types of erectile dysfunction clinics and that kind of thing just aren't taking place at the moment. So we've seen a huge increase in demand for that service. And also our fatigue support service as well. Fatigue is a very common side effect for hormone therapy treatments. So we have a bespoke service that a section of our nurses run, who are trained in motivational interviewing techniques and that kind of thing. And it's a series of telephone calls that they will have with men where they will help them manage their fatigue. Obviously, we can't cure it, we can't take it away, but we can certainly talk about interventions and things that they can do to help manage their fatigue. And if you could just press return again for me, Neil, you'll just see that, you know, what we're here to do is we're here to talk, we're here to listen, we're here to support and provide information. And, you know, the real luxury that we have that our colleagues in the NHS don't have, and I'm sure, you know, yourself, is time. You know, so it doesn't matter if somebody wants to talk to us for 5 minutes or 50 minutes. You know, we're very, very lucky that we can give them the time we have. And so, you know, we very much see ourselves as a service to complement the services that others are offering. You know, and when resources are stretched, and our colleagues, like I said, in the NHS and in other areas are really stretched for time, you know, we're very lucky to be able to sort of devote the time that people need to talking about that. Next slide, please. Great. So these are just some of the common themes that people contact the specialist nurses about. So treatment options is a very common one. You know, prostate cancer is quite different again to a lot of other cancers, where if you are diagnosed with it, a man will often be given options. So he might be told, you can have surgery, you can have radiotherapy, or, you know, we can even monitor this. Go away, have a think about it, come back and tell me what you want to do. And people really struggle with that, and I can completely understand that. You know, because if you're going to see the doctor, you want to be, you know, you're the expert. I want you to tell me what to do. But you know, that's often not the case with prostate cancer. It can be that either of those options, surgery or radiotherapy, are completely sort of viable and reasonable, and it's up to the man to decide. Now, again, we can't tell them what to do, but what we can do is talk about the side effects of each treatment, what it were to mean if the cancer were to come back, if you were to have one treatment, and you know, the impact on their life. And treatment options can often be very long calls, because as I said, if you're potentially talking about 2 or 3 different treatment options and everything that's associated with that, they can be quite long calls. But they are one of the most popular, one of the main reasons for people contacting us. Living with hormone therapy, as I touched on fatigue and that being a side effect of hormone therapy, but there are many other side effects that come with hormone therapy as well. So, you know, that's something we will often get contacted about. Side effects, incontinence and sexual function, as I said, are 2 very common side effects of surgery. What is the PSA test? You know, people want to know about the PSA test and what it means and how they can get it done. Signs, symptoms and risk factors. Living with advanced prostate cancer and prognosis as well. So these are some of the common, you know, common sort of things that people will contact us about. Next slide, please. So that's it from me. Apologies, I know it was a bit of a rattle through and a bit of a whistle-stop tour, but I was just sort of conscious of time, so I wanted to try and make sure that I got everything. I did, what I did want to share with you was our TV advert, but I'm having a bit of a problem, unfortunately, with playing it. Neil, I don't know if you might be able to stop sharing your screen for 1 sec, and I can try and share mine.
I might have to make you co-host.
Oh, okay. Shall I try?
That's done, so you should be able to now.
Can everyone see my screen okay?
It's coming up.
Yep, brilliant. It's not playing the volume too well, so I might just have to play it without, but you may have seen this or not. This is our television advert, and it was on, we launched it about 2 years ago, and it's been on again recently. And it's a shame you can't hear it, because it actually has Zoe Wanamaker, who's reading a piece from Hamlet, What is a Man from Hamlet. And all of the people that you can see in this film are our supporters. So, you know, they're not actors or anything like that. You know, they're people who supported the charity. And they basically took their own videos about, you know, what is it to be a man, and what does being a man, a father, a brother, whatever that, you know, whatever that may be, what does it mean to me? And we put this television advert together sort of from all the videos and things that they sent us in. Sorry, like I said, I'm sorry you can't hear it. For some reason, it does seem to be messing about a little bit at the moment. This is why Ali, who's a fantastic supporter of us. But you know, do go onto YouTube or something like that, and you will be able to watch it there, or you might even see it pop up on television, because it's doing the rounds again at the moment. So that is everything from me. Like I said, apologies, I did have to move quite quickly through that, but hopefully I got everything in for you. And I'm always really happy to share my slides at all, if that's helpful or anything like that. And yeah, really happy to take any questions if anyone's got any. I might just take a quick sip of drink though, bear with me.
There is some questions in the chat. Jane Hill has asked, is there a screening program in other countries?
Not that we're America sort of do something, but I don't think they call it a screening program. But they are a little bit more directive than we are in the UK. But in Europe and the UK, no, there isn't a screening program. No.
Wonderful, thank you. Stephanie has asked, do you have any advice on managing urinary symptoms for gentlemen who do not have routine access to toilet facilities, i.e. drivers and outdoor workers?
I mean, I think, you know, if they are having urinary symptoms and they haven't spoken to their GP about that or looked into that, that would always be my first suggestion, because, you know, if they're a driver or if they're working outdoors, you know, and they are suffering with urinary symptoms, it could be that, you know, there is an underlying problem there, whether it be an enlarged prostate or something like that. So, you know, first and foremost, that's always your first port call, because, you know, if you are found to have an enlarged prostate, for example, there's treatment, you know, there's things that can help manage that. And obviously then if you make your employer aware, you know, if you are somebody sort of driving for a living or working outdoors, obviously there are then things that, you know, they can then put in place to support you with that. But yeah, I mean, often it's about managing sort of lifestyle, really, you know, looking at what you're drinking, when you're drinking, you know, making sure you have access to a toilet as much as possible. Not probably really anything much different from what we would generally say in all honesty.
Yeah. Or you know where they are.
Absolutely. But what we do have actually, you know, what it's worth saying is we have a toilet card through the charity, so you can go onto the website and you can order it, or you can download it, a toilet card that men can show. So, you know, for example, if you're in a shopping centre or something like that, you can show this card, and, you know, most places, you know, will then give you access to their toilets or something like that. And, you know, that might be the same in museums or libraries or garden centres or whatever it is. So we do have a card that anybody can order. And we used to have something you might be familiar with it, called a radar key, which again meant that you could get access to sort of disability toilets and that kind of thing. You can't get the radar key on our website. I don't think you can get it anywhere now. I think the only place you can get it, you have to pay for it. But no, the card is free. No, you can just order it, or you can just download it.
Good. I've got a question actually. We had one of our webinars was a trans woman who had successfully gone through treatment or surgery. But if there are trans women that haven't gone through surgery, are they at any less risk or more risk? And I'm thinking less risk because their female hormones are going to be obviously being raised, aren't they? So is there anything there with the trans community that are pre-op?
Yeah, it's so difficult because it's such a small number of people. It's really, really hard to get any good kind of data on it. But it is an area that we're aware of, and we have actually done a real piece of work on it on the website. And we do have a whole section now that's kind of dedicated to trans women that does talk about risk. Absolutely. And, you know, if you have undergone hormone treatment, and also, you know, if you do end up being diagnosed, you know, what are some of the things that you're sort of because you know, it can be really, really difficult, as I'm sure you can imagine, to be a sort of trans woman, you know, potentially going into that environment. So we've got a lot of resources on our website, and we have got a dedicated section to that. But it's really hard to get any good data on it because it's such a tiny number of people that you're talking about. But yes, we do have a whole section on our website sort of devoted to that.
Wonderful. And then my other question is about sexuality, particularly for gay men.
Yeah.
Are they at an increased risk, or is there no difference?
No, not at all. No, you're not an increased risk because you're a gay man. Absolutely not. But again, you know, what we do have is a sort of section on our website that's dedicated to that, because, you know, gay men sort of face their own challenges, particularly in terms of treatment afterwards, and you know, if they have had surgery or something like that, and, you know, it comes back a bit really to that thing about relationships, and so again, you know, we do have a section on the website that really kind of focuses in on that. But no, there's no increased risk. Absolutely not.
And I mean, I think years ago it used to be that when men had sexual problems after surgery or radiotherapy, there was obviously a time I remember very well where it was just tough.
Yeah,
it is what it is. Presumably that service is now increased, and there's a lot more demand for it.
Definitely, and like I was saying, sort of with the pandemic, you know, it really has been an area, unfortunately, that's been really impacted, because, you know, men will be going to those ED clinics, you know, and kind of having those face-to-face appointments, and that stuff is just completely dropped off the radar now. You know, if their CNS is ringing, then they might be saying, I've got your latest PSA result, everything was great, bang, gotta go. And you know, that's not a disservice to them, it's just because they're so stretched and you know their time is so precious. So absolutely our sexual support service, you know, has really come into the fore there, because our nurses who run that are CNSs with a particular interest in that background. So you're absolutely right, Neil, you know, treatments have really moved on, and you know, it's so important to talk about penile rehabilitation sooner rather than later, and all of that kind of stuff. And that's all the stuff our nurses can sort of talk to them through, and you know, talk about vacuum pumps and different devices and all that kind of stuff.
Well, I mean, I suppose, you know, some of these men have had nothing else to do in the pandemic, have they?
Absolutely.
So it's going to be a really important part of their lives.
Absolutely, absolutely.
I am a supporter, by the way.
Oh, thank you.
Yeah, I am a supporter. Has anybody got any final questions for Laura, please? Because we're dead on 9 o'clock. So if there's no final questions, so on behalf of IOH, the Association of Occupational Health and Wellbeing Professionals, thank you.
Pleasure, absolute pleasure.
Really, really informative. And it's certainly something that, you know, obviously, you know, we want to publicise, we want to offer support and what have you. So obviously we will be sharing this with members within the website. Obviously if anybody has any further questions, you'll see the telephone numbers and the website on the presentation. And obviously I'm sure Prostate Cancer UK would be only too willing to help. So
definitely, and you've got my email, Neil. You know, if there's ever anything I can help, you know, I'm always really happy to help or support with anything, or you know, you've got any questions, don't hesitate to get in touch. It's a pleasure.
Okay, wonderful. Thank you.
No worries. Have a good evening, everyone. All the best.
Thank you, Laura.
Take care. Bye-bye.
Thank you. Bye-bye.
So much, Laura.
Bye.
That's excellent. Bye-bye.
Guys, I'm going to stop recording now. So if you bear with me 1 second, I will stop recording when I can find